we can just dive right into it. And we always encourage people to post their LinkedIns if anyone wants to network or connect. But we're going to hear about Higher Medical and what they're building in Cleveland. But it's really incredible to see what's going to be spreading, hopefully across the country, maybe even beyond. And then after our presentation, we'll have some time for an open talk and Q&A. So with that, I'm going to stop sharing, and we'll see if you're able to share right now.
Yeah, I'll share.
Okay, perfect.
All righty.
Great.
Please ignore my desktop. It's a total mess.
Looks like mine.
Yeah. Well, I know, Chris, like, how do you usually do it? Do folks kind of give a small presentation up front and then just
exactly. You can walk us through what you're working on. If you want to make it interactive as you go, or open it up, or just wait till the end, we can certainly do that. But it's kind of your time. But go at your pace.
Yeah, and just interrupt me as we go, because I know people are going to have questions along the way, especially if you don't have a healthcare background. Just feel free to interrupt me. I want it to be as interactive as possible. So my name is Manoj Jhaveri. I'm the CEO of Higher Medical. My two co-founders are Dr. Faris El-Kadir. He is our Chief Clinical Officer, and then Oliver Cullis, who's our Chief Technology Officer. All three of us live in Cleveland. And we have a great team behind working with all of us as well in Cleveland, excellent advisors. And I'll show you a few pictures of certain folks. Wish I could fit everybody's face on that slide, but I have a lot of great people on the team. So I guess before I jump into things, Higher Medical started about 3.5 years ago. And really what we looked at in this space is that, and through a series of kind of lucky coincidences, I met Faris early on, and then later we met Oliver. But as I met with Faris and we talked about different projects and different ideas, he's got the healthcare background. He was actually doing a fellowship in GI at Cleveland Clinic. My background started as an engineer, mechanical industrial engineering. Then later went into management consulting. I was with Deloitte for a long time. About 8 years. And then I had my own consulting company focused on strategy and innovation with a lot of Fortune 500 companies. My background was not a startup pedigree at all. But I sort of fell into the startup world by accident. And I'm so glad I did, because I've really found a passion for doing this kind of work. The common thread for me has always just been about problem solving. And so I have more of the business background, Faris has more of the clinical background, and then Oliver has more of the software technology background. And when Faris and I were talking about different things that he was seeing in the healthcare space, the thing that came up a lot was the work he was doing as a freelance physician. Sometimes they call it locums work, sometimes they call it contingent. They have lots of different names for it, but it's basically when there's a massive shortage, and there are many, many shortages of physicians and APPs and nurses, et cetera, across the United States, especially in rural areas. I was reading a stat the other day that said metro areas have 3 times the density of physicians that rural areas do, on a comparison basis with the population. And so on a per capita basis, that's quite a huge difference. And so lots of rural and suburban areas just don't have enough physicians, and even many metro areas. And the way that this shortage is often alleviated is through locums or contingent providers. Contingent providers are really they're not filling in the place of someone who's missing. They are there on a steady basis, and some percentage of that hospital or medical group's workforce is composed of these contingent physicians who maybe don't want to live in that rural area, but they are going to travel there maybe every week or every few days or whatever it might be. But the problem that we saw in this area was that it's all controlled, kind of the staffing is controlled through these locum agencies, and the way they operate is pretty in a non-tech kind of a way. They're not really using a lot of modern technology. Even some simple things around just having a platform where there's visibility and transparency around what's happening, at various sites and what their needs are. What's the rate that the provider would make? what's the exact name of the location. Oftentimes agencies, they don't disclose any of that because they have often a high markup, and there's a lot of negotiating and haggling going on. So there's just a fundamental lack of transparency. The credentialing time takes months. It can easily take over 100 days, if not more, on average. And there's really a huge supply chain issue in this space in terms of getting people from saturated areas over to where they're more needed. And so that's how we kind of look at it. Is it's a massive supply chain challenge, and there's lots of antiquated ways of doing things, and it doesn't have to be that way. There can be full transparency and visibility, assuming if your markup's low enough, you don't worry about people going around you, right? You're providing value, and just like an Uber or a Lyft or anybody else, an Airbnb, they're transparent about what their rates are and what their fees are. And so we do the same thing. We felt that there's an opportunity to really build a technology company and a data company. And the first thing out of the gate we wanted to focus on is alleviating a lot of these shortages through freelance physicians, is what we call it, or freelance providers. But then we have a vision that goes beyond even just freelance providers into areas like medical groups and virtual groups to form on our platform and provide care in that way. So there's many ways you can alleviate a shortage. Our overall vision and mission is to break down these barriers of speed, of time and place, and allow for a better functioning marketplace. And so we focused on that problem, and we felt that technology played a huge part in this, and so we built a technology platform from scratch. So any questions? I know I mentioned a lot of stuff there.
Maybe Manoj, and if you're getting to this, I apologize, but
no problem.
The kind of founding story of how you and Ferris came up with the idea, kind of that beyond the business plan part, because at least from my conversation with Ferris, when I spoke with him for a podcast recording, it was really fascinating how this all kind of came to be, because it seems like you mentioned the business side, the healthcare side, the software side, that's like this perfect match of the team. So maybe just share a little bit about that, because I think that's a really good story.
Yeah, I mean, like I mentioned, I had a consulting firm. He was doing his GI fellowship at Cleveland Clinic. We met just by accident at a startup competition. It was one of those 54-hour, build a business hackathon type things. I was really there because I wanted to take some of those startup techniques and bring them to my clients, these larger clients that I was working with. Many of these large clients, Fortune 1000s, Fortune 5000s, they want to bring in a lot of startup techniques now into their organization to innovate faster. So that's why I was there. And Ferris was just kind of there for fun. And he has a data statistics background. He's into a lot of analytics and visualization stuff. He actually likes to code as well a little bit. And so he's kind of a unique physician in that way. So he did a bioinformatics fellowship as well. And so we just met by accident. He was pitching an idea for something completely different at this startup competition. And we started working together for those 54 hours. We kind of became friends quickly, and we won that competition. And then, kind of from the excitement of winning that thing, we went forward with a particular idea. And it turned out that idea didn't work out. It was not going to have enough fuel and enough potential. But in working on that together, we started talking about other ideas, and one of those became what is now Higher Medical. Actually, the initial company was called HIGHER, Higher Medical, and then we renamed it to HYR. So I still have some of the old logos of the Higher Medical, HIGHER. So and then we rolled from there. I mean, we met Matthew Miller, who at the time was at BioEnterprise. I mean, neither of us had ever worked with an incubator, and we had very little startup experience. So Matthew helped us a ton. We incorporated, we started working with LeanDog to build the MVP software, because we didn't have a CTO at the time. Then we slowly brought on additional advisors. Nick Barrett, Charlie Lougheed joined us as an advisor. And Had a few other great advisors as well, like Gene Groyce, and we started expanding the team slowly but surely. We started getting revenue, started adding providers and hospitals to our network, and now, fast forward, we have over 1,000 providers on our platform and over 30 clients signed up with Hire Medical. Chris, does that give you a good idea?
No, that was perfect. Thank you.
Okay, no problem. A little bit more just background into this industry. There's a massive shortage of providers. That's no secret, and COVID has exposed that even more. The biggest problem, though, is the mismatch of supply and demand in localized areas. Like I said, you have areas of the United States that are saturated with doctors, like downtown Cleveland, but then you have places like Ashtabula that are dying to have more providers, right? So it's not about the raw numbers. This is more the raw numbers, but really when it gets even worse is when you look on a localized level, especially in rural America. It's a massive industry. I mean, healthcare staffing itself is an $18 billion industry, and it's just growing. I mean, it will be a $25 billion industry in 5 years. Healthcare staffing, when I say that, it's talking about locums or contingent providers for physicians, APPs, nurses, as well as allied health. Hire Medical focuses on physicians and APPs. There's actually a decent amount of companies that are looking at the nurse problem. We seem to be one of the only ones that's like an online platform that is hyper focused on physicians and APPs. And part of that is our pedigree. We have a lot of physicians as part of the company, and we understand this world the best. These onboarding delays that I mentioned to you guys, 100+ days to get a doctor not only matched up properly with an opportunity. So you got to consummate the match and match supply and demand. But then this whole thing about credentialing and privileging begins. And it is a very manual process in today's world that, I mean, without going into all the details, it's the entire workup and history of that physician and everything they've ever done and all their licenses and all their case logs and, references. And I mean, I could just go on and on. There's a list of so many things. And we're tackling that in a unique way in our partnership with Actual, which is also a Cleveland-based company. The CEO happens to be Charlie Lougheed, and he's, like I mentioned, one of our advisors. So we have an R&D partnership with them, and we are actively, we're already a user of Actual, and now we're integrating our platform with their API. And the workflow is going to be very different pretty soon, where providers join Hire, then they go through the Actual process, they get actualized, all their data is primary source verified, and it feeds directly into Hire Medical and pre-populates the provider's entire profile. So it's going to be a pretty slick process when it's all done. And we're really the one at the vanguard of doing that in terms of companies that are attacking this problem. So like I said, Hire is a technology and data company. It just happens to be that our tip of the spear is the locum and contingent staffing market, but we see huge potential later to also enter into things like teaming up providers or even group practices and supporting those groups with the technology and the support they need to serve locations in a group model as well. Any questions on some of this? One thing I want to mention is that every day that a provider's onboarding is delayed, it costs a hospital more than $7,500. So in lost billings.
Manoj, on here, it's the 50%, more than 50% of doctors are burned out and $1 million to replace. Is that if a doctor decides to quit or retire, and then it's the recruiting and all of that feeds into that cost?
Yeah, absolutely. And the signing bonuses and all of the things needed to replace someone who's just utterly burned out. And you're hearing about burnout constantly now with COVID, and the problem has become exacerbated. And so, really, if you look at Hire Medical's main website, the number one thing we're all about is putting the provider, the physician, and the APP at the center, and supporting them and allowing them to have freedom and flexibility and autonomy. And that's something that's very unique about our company. We're big about, providing physicians and APPs with a sustainable lifestyle. And that includes being able to quickly find positions and work when they want to work, and have a little bit more say in how they work. They may want to have an assignment where they work for 6 months, and then 6 months out of the year, they take it off and they travel, they spend time with family. And right now, the model that's out there for physicians is pretty unsustainable. And many physicians we talk to don't want to work as W-2s for a large system. They feel, overrun. The administrative aspects are also, very burdensome, and they feel like they have no chance to kind of catch their breath. And so a lot more providers are choosing this as a lifestyle, as a way of life. And so that's a big part of our value proposition.
I have a question. I have a really dumb question, but I'm going to ask it anyway.
No worries.
Just given what we saw, again, I was talking to Chris before, and no matter which side of the aisle you're on, in the past several months, the disaster of rolling out the vaccines and all the guesswork and all that. And originally, we were talking about the military. Have you all thought about, this is why it might be a really dumb question, as a contingency where, God forbid, this happens again, any type of natural disaster or illness, a pandemic, this is a tool for federal government or state or FEMA in terms of employing for quickly matching or filling slots for doctors?
Yeah, absolutely. I mean, our goal is to be a solution that allows for very quick and actually automated matching of supply and demand. Right.
I mean, could the federal government be a potential client to be able to, license the technology, I guess is my question.
I think they could be. I mean, I think, like, let's say you take New York, for example. You had, I think the number was 90,000 people volunteer initially in March and April of 2020 to provide help there. Of that number, I think it was somewhere between less than 10% of those providers were allowed to actually practice in New York. And honestly, the entire reason is the credentialing bottleneck and the ability to vet these people on a quality basis and quickly present them. And our technology allows that to occur.
See, that's what I'm saying, as the potential, as a contingency that, God forbid, as this world gets crazier with natural disasters and illness and pandemics, what have you, that this is a tool that's sitting ready for federal, state, or local to be able to employ, besides just those providers that, or as a service to the providers. I don't know.
Yeah, no, that's a great point, Dan. I mean, that's spot on. And so we're always trying to make our matching technology more accurate and faster. And one of the things that we are doing right now is really building up it's more than just a CRM. It's more of a provider omni-channel communication tracking tool. It integrates all text messages, emails, phone calls, anything that we do with the provider is in one spot. And then ultimately, we're going to use machine learning to actually enable really deep understanding of each provider. And that in itself, provides a better matching ability. So if a certain physician, wants to practice, but they don't like to do procedures, or they don't want to intubate, or they don't want to do a central line, that type of thing will be known by our machine learning engine. So one of the reasons we are at the early stages of raising some more funding and stuff is because of the need to even build even more technology like what I described. There's even more we want to do on the employer side of the platform, and then of course with the integration with Actual, that's really gonna up the bar even more. Every provider that goes through Higher Medical now has to get actualized. And so their primary source verification will be done. Now the question becomes, how do you convince the hospital systems to accept those credentials? And Over time, that will happen though. And that's obviously the thesis that Actual has as well, is that over time, we start working with more and more systems and we say, hey, look, if you want to really reduce the time to practice for physicians, and not only are you reducing time, but that revenue number that I mentioned, losing over $7,000 a day, what happens is that when you're a hospital, you're under a lot of revenue pressure. So you say, you know what, we can't afford to reduce the throughput of our hospital. We have to keep billing. So we're just going to work the people we have harder. And that eventually catches up with you and leads to burnout. So if the supply chain for talent and getting new people in the door is like 10 days instead of 90 days or 100 days, that's a massive improvement. And our ultimate goal is we want it to be like 0 days. If you want someone and they're actualized, they've already been primary source verified to the level of JCO and NCQA standards, bring them in and autofill all the documents or use our standard hospital application. Again, these are things we really want to occur. I think the reality is it's going to take some years to get there, but hospitals don't always move extremely fast, but we're going to get there. And I think this country needs it because the shortage and the burnout problem is just getting worse and worse and worse.
Hey Manoj, Firoz here. If I may sneak in a question again.
Oh yeah.
So maybe this is just a follow-on to what Dan had brought up. And so what do you, maybe a two-part question. So what do you see as the biggest bottleneck for you, more from a demand side to scale? And secondly, whether it's driven by regulations or just the accessibility for the employers. And also, if you see this in the long run scaling beyond the US borders, do you see that happening as add-on base that you can address?
Yeah, I mean, I'll take the second part first.
Place, right?
Yeah, I mean, in terms of outside the US, I'll be honest, we haven't thought about it a ton because there's so much opportunity just in the US and the market size is enormous, like I mentioned, and the problem is enormous. But yeah, eventually we will. I mean, it may start off with something like telemedicine for folks that are overseas. That's actually a huge market, and we know a little bit about that. I mean, actually, in the United States, I mean, yeah, healthcare costs and things like that are out of control, but from an education standpoint, people still revere, U.S. physicians as some of the most, the best trained physicians out there. So people overseas want to see American physicians, and use telemedicine to do that. So that's actually an area of growth. I think we ultimately see ourselves allowing for the formation of virtual groups and offering like telemedicine overseas. As far as the demand and the bottleneck and things of that nature, I think that I guess from a demand standpoint, we have to make it, our company needs to make it easier and easier for organizations to onboard with us, to sign up, to start posting jobs, and that's something that we're working on to make even easier for them to do. That's kind of it's on our roadmap. But then we have to do a lot more education of the market and help them understand, things like digital credentialing. Why is that so important, and how, there's a lot of institutional kind of thoughts about how they have to do things in terms of primary source verification and things like that. And a lot of the ways that they think they have to do things or that they think their bylaws require, they actually don't require. It's just that they've always done it that way. So in most cases, their bylaws don't say that they, for example, have to do all the primary source verification. They can use a third-party CVO, credentialing verification organization, to do that work, but they traditionally have not. They've kind of kept everything insular, and they said, we have to do everything to verify this doctor. And there's a lot of like repetition of the same activities and verifications over and over and over again. And so that's just one example in the credentialing space. Just in the this whole matching technology that I described, that in itself too is a big way to reduce friction in the marketplace.
Makes sense. Yeah.
So I can jump onto a few more things here. I'll just kind of laying the foundation for the problem that we're tackling. So we're focused right now, at least, on the locum and contingent space. We do also post some permanent and telehealth jobs, and then later this year we'll be posting jobs for groups and for teams. So instead of a job that says we need one provider, it might be we need an entire virtual group to take over and contract with for, let's say, GI or OB, or we want to have an entire outpatient group that we contract with. And that's where our model will change a little bit from transactional model. We have a 20% markup on the provider's rate to one that is probably a little bit more of a SaaS model or a percentage of the contract model. So that's an area that we feel really strong about as well. In a nutshell, high level, this is where we're at right now. It's a two-sided marketplace for freelance providers and medical practices. We're totally transparent. That's not, like I said, how agencies do things. They are notoriously non-transparent, and there's all kinds of discrimination and rate haggling and things that occur against women, minorities, I mean, you name it. And what the agencies are trying to do is push down the provider as much as they are able to, and try to increase the spread between what they bill the client and what they pay the provider. And they don't want to reveal anything that would allow the provider to not be locked in, and then get around them and then go direct to the provider or to the employer. Our philosophy is that we give a much higher rate to the provider, and so that increases the amount of applicants and the speed with which applicants apply. By having a small spread between what we pay providers and what we invoice hospitals, it kind of disincentivizes them to go around us. So it's because we're also providing the medical malpractice, we're providing help with their licensure and helping with credentialing and all these other things that we add of value. It's kind of like the comparison I make is if your Uber driver drops you off at the airport, you generally don't ask the Uber driver for his mobile number. And then when you land again, you call up the Uber driver because you don't even want to deal with that because the convenience factor is valuable to you and it's worth the 20% markup. Same thing with like an Airbnb. I mean, if I'm an Airbnb host, someone stays at my house, and I actually used to Airbnb my house in the early days of Hire Medical because I was making ends meet. And I'd have people ask me sometimes, like, can I just get your number and then circumvent Airbnb next time? I said, no, it's not worth it because Airbnb provides insurance. Airbnb provides other ancillary benefits. I don't want to get caught doing this because I don't want to lose my hosting privileges. So that makes a big psychological difference. But when the markup, typical agencies have a 60-70% markup in many cases. So there's a big desire as a physician to go around them. And so therefore, there's a big desire for the agency to be non-transparent. This is just some screenshots of the platform, just so you know that there's an actual product here. There's a provider side of the platform and there's a medical practice side of the platform. And this just shows some of the matching technology as it exists today. When providers join the platform, they're going to get email and text-based notifications, and our iOS and Android app allows them to also get push notifications to their phone. I talked about this a little bit, but really what Hire Medical is all about is breaking the quality and speed trade-off curve. So we're able to not sacrifice quality for speed, and we don't have to sacrifice speed for quality. We're able to do both faster than anybody else. We're able to quickly, what we call hire certify a provider, getting them primary source verification, doing a clinical interview with them, getting a background check electronically. We're partnered with Assurant, another Cleveland-based company for that. So we're able to do a lot of things to vet the provider right up front, and in hours and days versus weeks and months, get that provider working. If the provider accepts the actual digital credentials, that's the holy grail solution. And we are starting to actually have a couple of our biggest clients now look at Actual. So it's a give and take with our two companies to help each other from a sales perspective. So we have a lot of opportunity for that between the two companies. I kind of think of Actual as like it's one important recipe or one important ingredient in the overall recipe. It's kind of like the engine of our car. So if we're the sports car, they're the engine inside. This is just the funnel of all the things we do from a vetting standpoint for the providers. We're not about necessarily having the largest network. I mean, I think we will have the largest network ultimately, but that's not our focus. The focus is really on having the highest quality curated network that's ready to go and on demand. Just a few things about our process itself. I skipped some of that, but our team, like I said, 3 co-founders. Joyce is no longer with us, but Heather is our marketing director. We have a deep clinical bench as well as our clinical advisory board. And then we have numerous advisors and employees as part of the company as well. So the total team is about 12 people. And this is just a little bit about where we started, some of our key clients. We beta launched in 2018 and started generating revenue, added telehealth and APPs to the platform, did our mobile release, and now we're doing the integration with Actual. And like I said, we're at 1,000+ providers and over 30 clients on Hire Medical. And this is just more about the market, how we go to market, different types of personas that we look at. So there's a lot more to this whole thing, how we stack up against our competitors. Nomad Health was our largest competitor, but they've done something interesting. They've really pivoted out of looking at physicians, and they're almost completely now nurse focused. They really are not focusing on the physician market, which we're frankly kind of happy. But it's always good though to have some competitors. So Lucidity is focused on the same market as us, and then you have large publicly traded companies like AMN Healthcare, which AMN is a large publicly traded company, but they're a traditional staffing company, and there's hundreds of these out there. There's probably about 400 traditional staffing companies, all the way from publicly traded to mom and pop, that are out there. So, where we're headed as a company, I always like to show people this slide. In 5 years, 1,000 practitioners working on the platform, 50,000 shifts being completed per year, and significant net revenue and shareholder value. So happy to answer any other questions you guys have about Hire.
Do you think those numbers are conservative? Because I think your solution is amazing. And I think there's more, I really do. And Chris knows, based on what I'm doing, which you'll hear about sometime in the future.
Yeah.
The online marketplace is a very interesting concept. And I really do think this is something special. So that 15K and the 5 times multiple, that looks conservative to me. Is that just pure humility or
I mean, it's we've created a financial model that we think is achievable. So, if we want to be at an annual run rate by the end of this year of 1 million plus ARR run rate, and then we want to, we're actually able to operate in a pretty lean way. We're maybe doing things a little bit differently, so we probably won't raise a Series A financing until end of 2022 or beginning of 2023. And so we're doing things a little different, but I think we're, I think that's kind of the cool thing about Cleveland-based companies. We're kind of, gritty and resourceful and able to do things without necessarily raising like, a $5 million round.
God love you. I think you're going to see even, what I know, I'm a layman, but I think this is such a understandable concept and so much in need. The past year has proven that in terms of getting everyone's attention. I think that's I wish you well. I think you're going to see more, so
That'd be
That's just my
amazing. Thank you though. Thanks, Dan. Appreciate that.
Yeah, no, I think, Manoj, this is phenomenal, I think. And so, Chris, just in case you didn't know, Manoj and I are classmates at Ross. So we did our courses together. And I think ever since Manoj has been absolutely active in terms of thinking of ideas and ways and means of identifying white space in the market and how do we address it. I think the platform that we have created, Manoj, is absolutely portable to, just like Dan said, in terms of scalability, it's not just the medical practitioners, right? You can extrapolate it to so many other fields itself within the medical domain.
Yeah.
And I think be it equipment providers to hospital facilities or stuff like that. And I think there's a phenomenal potential for scaling.
Even in different verticals. That's why I see.
Just as a quick background about myself, based out of Columbus, Ohio, essentially an engineering services firm. And I think Manoj and I had exchanged notes earlier as well. I think in terms of even engineers providing their services as freelancers, right? I mean, that would open up a whole new spectrum of potential opportunities.
Yeah. So, I mean, we're trying to stay somewhat, focused, but yeah, there's going to be things that open up. And I mean, one of the big things we see is this, the formation of virtual groups and physical groups as well of practice. And because when we go from 1,000 to 10,000 providers, I mean, all kinds of things become unlocked. And the biggest thing we think becomes unlocked is that quality vetted physicians are able to connect with other quality vetted physicians. And then there's a social component to our platform. And then they're talking about ideas with each other and saying, hey, look, there's a need here at this hospital for a group. And let me find 5 other GI physicians and I'm going to get that contract. So what we want to be able to do is provide ultimately the toolkit that they need to spin that up quickly. So everything from telemedicine platform that we have a partnership with to billing and coding to cloud-based EHR, all the things that you need to basically rapidly spin up a practice. and a lot of that's going to be happening virtually too. I mean, obviously telemedicine is here to stay and it's only going to grow.
Bob, is that your
Bob.
hand up?
Yeah, it is. Yeah, I was just going to jump in and say that, I'm glad you guys were able to find a way to handle that credentialing issue. So I seem to recall I was on the Innovation Fund's initial review panel when you guys pitched up there. And the whole part of credentialing, I think, was one of the big topics of conversation we had. So I think one of the things that we had was if you guys could crack that nut, so to speak, then that would be the linchpin to your ability to scale this thing. So I was just glad to hear that you guys have kind of figured that out. And now it's a matter of just kind of time and people getting used to it and adoption and, breaking down the bureaucracies that they've built because that's the way we've done it.
Yeah. And there's a lot of that. I mean, and certainly the hardest part of this marketplace is getting the flywheel going. And now we've sort of overcome, a good part of that. And we have enough providers and enough clients where people feel like, okay, this is a credible marketplace. And, but that's the hard part, right? Like it's a chicken and egg problem with any marketplace. And like, how do you get that critical mass? And we tried to do it more from a get the jobs and then do everything possible to get the doctors. So kind of use the job as kind of the honey that would then attract more of the bees, if you will. And we looked at it from that kind of virtuous cycle. You got to start somewhere. So that's how we were able to kind of get the flywheel moving slowly, but now it's moving faster. All right. Chris, any other questions or?
Yeah, open it up if anyone has anything else. These have been great. So thank you for walking through it and everyone for hopping in with different things. So
absolutely.
Hey, there's anything to add or anyone else?
I had a quick question.
Yeah, please.
Hey, Manoj, I know it's been a little while.
Yeah, I haven't seen you in like years.
Right, I was gonna say since 2017, I think.
Yeah, man.
as a little bit of background, Manoj was a professor of mine when I was doing the Masters of Engineering and Management program at Case a few years back. But I guess I had a question, especially given the last, the last year and what we've seen with people kind of transitioning, with physicians transitioning to providing different kinds of support based on specialties and their levels of training. Have you seen more people, sign up, physicians that are maybe not yet practicing? So is it still within residency programs, or transitioning to various fields of practice?
Yeah, definitely we have some third year, fifth year residents sign up with us. In many cases, board eligibility or board certification is required by most of our clients, but not always. And actually, the very first doctor we ever placed on hire was not board eligible. He was in his third year of residency. So it does happen, but it's less common. So, and we're trying to do a lot more. We're actually spinning up a project here pretty soon, where we are trying to focus more on the residency programs. That's one area of untapped opportunity, I think, for us, is just getting more early education about what hire is. And we've had some good word of mouth in that way, but we need to do more to get to the administrative directors of these programs. And there's hundreds. I mean, there's probably 500 residency programs in the United States. We want to focus in on the ones that are going to have the highest impact for us. But yeah, that's a good point. I mean, and I mean, this idea of having freedom and flexibility and ownership and more agency of your career is obviously something that is very appealing to the younger generation. So it's also very appealing to the older generation, by the way. 60% of freelance physicians are above the age of 50. So what's happening is that you have providers who are semi-retired. They want to practice, but they can't handle, and they don't want to handle the method by which of being a W-2. So they're like, look, I'll work on my own terms. I'll work 6 months and then I'll take 6 months off and I'll see my grandkids or whatever, right? So that's a big part of what our value proposition is to people. It's the transparency and the speed and the quality, but it's also we're positioning hire as a lifestyle brand as well. So from an outward facing standpoint, we're all about the ease and the speed and the the lifestyle that it can provide to providers. And in turn, by giving that to providers, it's actually helping the employers, because then they don't have the burnout issues. They have providers who are more refreshed. They have less medical malpractice. They have all those things, less turnover, right? So, and they're generating more revenue, because if you can get people staffed quickly, like I said, you have better throughput basically through your hospital, and you have shorter waiting times. So, but our focus initially, our center point is the provider. And by making things better for the provider, you make things better for the employer. And by making things better for both of them, you make things better for the patient.
Kind of as a follow-up, have you seen physicians kind of go through hire, be placed, and then kind of at that point end up coming on full-time as a full-time employee of those healthcare providers? Just because I know, and obviously it's a different experience with physicians and nurses, but oftentimes with travel nursing agencies and things like that, those gigs are like you said, 3 to 6 months, and a lot of times, depending on location, nurses will want to stick around for longer periods of time. So again, I don't know if you've seen the similar thing with physicians.
It's interesting. We've had a couple of our providers who are freelancers who have been offered jobs by our clients, and they've turned them down. They said, no, I value my lifestyle too much. I want my freedom. I want to be my own boss. So we attract the entrepreneurial kind of providers, I think, definitely. And we placed one person so far for perm, but typically we're a platform for, enabling the, whatever you want to call it, the gig economy, or whatever word you want to use.
Yeah, of course. Thank you.
Yeah, no problem.
Okay, well, any other questions, or Manoj, a final comment or anything before we head out?
I just wanted to say thank you to everybody. Really appreciate the feedback and comments. I love the work, Chris, that you and OhioX are doing. You guys are just awesome.
Thank you.
So yeah. I got to start going to more of your events because just got to find time and carve it out, man.
That's the tough thing, isn't it? But no, Manoj, thank you so much for sharing your work. And as I've said at the beginning, when I first, we first met, and I've met Ferris and talked with Heather from the team too. It's fun to follow along, and as Dan said, you hear it and you get it, and to see some also, I would say the healthcare innovation that's being built up in Cleveland specifically and across the rest of the state. It's really fun to see a company like yours and this idea that you all have been building. So thank you for doing the hard part and also sharing it with us. So we appreciate it.
Yeah, I appreciate it. Thanks, buddy.
All right. Well, everyone, thank you so much. Hopefully it's a little sunny and warm, and we can, get off of the Zoom and go outside. So thank you everyone for joining. Manoj, thank you again for sharing your work, and we'll see everyone next time. Bye-bye.
Awesome, man. Thank you. Bye-bye.
Bye.